Hi, PE 111. Today we're going to go over Chapter 18, different eye pathologies. So you're probably wondering, how often do we really have an eye injury? And it actually happens much more frequently than you would expect. One of the things that we check in the pre-participation exams is their visual acuity, and we're going to talk about that a little bit later on. You guys have probably seen a Snellen eye chart and had your vision tested, and you've probably heard about 20/20. So we'll get into that a little bit more, but also think of those that maybe don't have corrective lenses and don't necessarily know that they need them, whether it's contacts or glasses. That, and then even with healthy eyes, we end up having, if we're working on or playing on turf, the little track pebbles, the little rubber pellets, often get lodged in the eye, or bugs or eyelashes or grass, whatever the case may be. So we deal with that a lot. So it is important for us to know our anatomy, be able to take a good history and evaluate an eye injury. Okay, so our clinical anatomy. Going specifically and looking at the bones, some of the bones, or actually the bones that form the eye of the orbit, are going to be our frontal bone, our sphenoid, our zygoma, the maxillary, the lacrimal, the ethmoid, and the palatine. So besides protecting and stabilizing the eye, the orbit serves as an attachment site for some of the intrinsic muscles acting on the eye. Now, what the heck does that mean? So let me see. Let me go on here. So with the orbit of the eye, not only it will also help track how the eye, the orbit moves. So when we get into concussion and assessment testing, we usually tell the athlete to follow with your eyes, follow my finger with your eyes only and not your head. So you're having them look up, look down, look straight, and then go to the right and left, depending on what side you're at. We don't want them moving their whole entire face. We want them just with the eye. With that, it is affiliated with different cranial nerves, and we're going to go into that shortly. But each of those plays an important part on if there's a fracture, there could be pinching of the muscle that actually helps that eye move. It doesn't always mean that if and when there's a fracture that it is always visual to the naked eye. There's times where somebody got elbowed and wasn't getting better, the swelling wasn't going down. We waited a day, went in for x-rays, and sure enough, they had a fractured bone. Okay, getting a little bit into the actual eye structures. So the globe, kind of self-explanatory, and then eyelids. The reason eyelids are important is because they help us blink, they help keep the eye moist and try and remove any type of debris that's in there. You might have woken up in the morning and had sleep in your eye on either of the corners. That's one of the things that the eyelid does. The more that you blink, the more it kind of wipes out any outside entities from the globe. And then we have the sclera. Pointer. Okay. The sclera. It's a tough white sheath around the outside of the eyeball. It's a part of the eye that is referred into the colloquial terms the white of the eye. Okay. We have right here the pupil. Okay. With that, the pupil is the aperture through which light and we're able to see images and the perception enters the eye. It's formed by the iris. As the size of the iris increases or decreases, the size of the pupil increases or decreases correspondingly. Okay, and then specifically talking about that, with the iris is a diaphragm of variable size where the function is to adjust the size of the pupil to regulate the amount of light emitted into the eye. Basically, when we're checking pearl, pupils equal and reactive to light, The iris is what's kind of controlling how much light is letting in. The iris is the colored part of the eye. So when I'm asking for concussions, what color their eyes are, because I don't know what everybody had for a pregame meal, but I do know what their eyes are. I feel bad for the ones that tell me, oh, it's hazel, I swear, or it depends on what color shirt I wear. I'm going to give that to them, okay? I'm not just being mean. And then right here, if we go, it's not letting me. Right here for the lens. The lens of the eye is a flexible unit. It consists of layers of tissues that enclosed in a tough capsule. It's suspended from the ciliary muscles by the zonulus fiber. Then, I don't know, did I talk about the cornea? The cornea is a strong, basically clearish bulge located at the front of the eye where it replaces the sclera that forms the outside of the surface on the rest of the eye. The front surface of an adult cornea has a radius of about 8 millimeters, and the cornea contributes to the image forming process by refracting light entering the eye. Okay, the conjunctiva is normally kind of what I talk about with the white part of the eye. You might have heard the term conjunctivitis or pink eye. Pink eye is basically inflammation of that conjunctiva. That's why it's called conjunctivitis, and usually gives the eye a kind of pinkish coloring. It's very, very, what's the word I'm looking for? You're able to spread it. It spreads like wildfire. So if one person on the team ends up having it, there's a higher probability that the rest will end up getting to it. Whether you guys are touching your face or touching, whether it's a volleyball or basketball, and then ends up touching your face, if you use the same towel, it can definitely cross contamination and infect others very easily. And I want to talk about the retina and the sclera. The retina can be described as a screen on which an image is formed by light that has passed in the eye via the cornea. The retina contains photosensitive elements called rods and cones, which we'll talk about in a second, that convert light that they detect into the nerve impulses that are then sent into the brain along the optic nerve. And then the sclera is a tough white sheath around the outside of the eyeball. It's the part of the eye that is referred to in colloquial terms, kind of the white of the eye. And then I did want to talk about rods and cones. Rods are especially important for vision in dimming light situations. They have a pigment in them that's broken down or bleached kind of for bright light and regenerated in darker conditions. The activation of the rods by regeneration of rhodospin in dim light together with the enlargement of the pupil of the eye are the key process associated with dark adaptation. So when you wake up in the middle of the night and you're trying to walk around in the dark, your rods are what's really helping that aspect. Cones, on the other hand, are important in vision where there is bright lightning. So for acute vision or receiving sharp, detailed images and color vision, there are three specific and then the optic nerve. The optic nerve is one of the 12 cranial nerves. The optic nerve, what we're assessing is the visual acuity. So a lot of times when I'm on the sidelines or in the middle of the basketball court, I'll point to the scoreboard and ask them how much time is left on the clock. One of the reasons I ask time is one year we were horrible and we were always losing, so let's not make it even more depressing. But I want to see if they have diplopia, where it's double vision, or if they can read that far away. Hopefully I've already had a mental note who on the team is wearing corrective lenses or has contacts, and I'll ask them if they're wearing their contacts, because if not, it's not fair for me to judge them in that aspect. But the optic nerve, cranial nerve 1 is one of the things that we're assessing in a concussion evaluation. And then with the muscular anatomy, there are oblique muscles that are responsible for rotating the eye inferiorly and superiorly. And then there are rectus muscles, both inferior, superior, medial, and lateral. So a lot of times when I'm having people follow with my finger with their eyes, and I have them go up, down, right, left, that's actually assessing cranial nerves 3, 4, and 6. So that's important to note. Visual acuity. Okay. So with this, usually we'll use a Snellen eye chart, and I believe I have one later on in this PowerPoint. But with the Snellen eye chart, depending on the font of the chart, it'll tell you how far away to have the patient. And we're going to have them read certain lines, both with both eyes, and then with one eye covered, and then with the other eye covered. Okay. So emmetropia is basically 20 out of 20 vision. That's perfect. That's what we want ideally. It's for the ability for a person to read 20 feet from what a normal person should be able to read at 20 feet. Okay. If maybe their vision isn't as good, you might have 20 over 40, where the athlete's ability to read at 20 foot what a normal person could read at 40 foot. Okay. And then we've got some other terminology. Myopia means nearsightedness. Hypermetropia or hyperopia is farsightedness. Diplopia, D-I-P-L-O-P-I-A, I believe, is double vision. Okay, so those are going to be important to know. So if one of the questions on the quiz asks, what is 20 out of 20 vision called, you guys would want to say emmetropia. Okay. So clinical examination of the eye and eye injuries. We want to get a good history, see if they've ever had vision issues in the past, if they have corrective lenses. Let's make sure that they're wearing them. If not, maybe they can't wear glasses during football. Hopefully they're wearing contacts or whatever their sport is. I do note that with football, if football athletes are wearing visors, they have to be clear visors. Even if you have a doctor's note saying that you need tinted visors, even in college, they don't do tinted visors anymore because the healthcare providers need to be able to see and check if the pupils are reacting to light. Okay, so that's one of the reasons. So history, ask all those same pertinent questions. Inspection, do a visual inspection and look for coloring, discoloring, swelling, the movement of the eyes, and then you can go on to the palpation. Again, this is one time where I would ask the patient where they're having all the pain, and then I'm going to palpate further away from the pain and then start going towards it. Functional assessment, so being able to read signs far away, tell how many fingers are holding up, whatever the case may be. And then neurological exam, we're going to get more into when I talk about the concussion evaluation, but we are going over some of it here. And then there are a couple of different special tests and pathologies that we'll go over. Okay, so when you're evaluating an eye injury, there's a couple of things that you need or that would be nice to have. Now, a Snellen chart or similar, I don't carry a Snellen chart around. I do have a handheld, smaller chart, but I think whatever you have around that area will suffice. There's an occluder. I usually have a pen light. If I don't have a pen light, most everybody has their cell phones. And what app do we have on our cell phone that we could use in lieu of a pen light? Hopefully you said flashlight. Cobalt blue light, I've never had. That's usually more in a clinic setting. Small mirror we have, and then the fluorescent strips. And again, the fluorescent strips is usually something that the team physician or an ophthalmologist would have. Okay. Other things, eye shield or an eye patch. The eye shield Usually we're using that when we're looking at the Snellen eye chart. You don't necessarily need a shield. You can have them cover their eye with their hand. An eye patch sometimes is necessary when maybe they have a scratch on their eye and it's mandated that they wear an eye patch. It's hard for them to actually abide by this, but it's something that will help them heal much faster and reduce the risk of having any permanent damage to that eye. Tape, plunger for removing hard contact lenses. I think nowadays most people have the soft contact lenses. And usually they're pretty proficient at putting them in and out. I do remember one patient where they were fairly new at using contact lenses, and the contact lens, she thought, got lost on the backside of the globe. So that was fun, trying to figure out and have her move her eye in different manners to be able to see that, all to find out that it had come out on the gym floor. So careful, but it's better to be safe than sorry. We should have saline solution, sterile cotton swabs and gauze, antibiotic eye drops, and not just Visine. I've talked with a couple ophthalmologists and they say Visine is not the best for the eyes, depending on what condition or what you're trying to treat for. We do have steri strips or butterfly bandages. That's not necessarily for the globe part of the eye, but it would be for any lacerations or anything that accrued on the eyelid or on the skin around the eye. And then always I'm going to contact an ophthalmologist. The eye and the vision is not my particular area of expertise. Give me muscles, bones all day long. I know basics with eyes, but I want to make sure that we're not going to have any everlasting, negative aspects for that. So I'm always going to refer them to an ophthalmologist. Also, if there's some type of chemical or whatever the case may be that gets into the eye, we want to make sure that we're contacting the Poison Control Center, and there's an 800 number, or get some information from the hospital. When in doubt, always refer them. Believe it or not, I did have a athlete who had accidentally, I don't know how, but sprayed Windex in her eye. So we're rinsing her eye out and finding out information, and that's basically all you can do is rinse the eye for however many minutes with cool running water. But you always, you never know when things or treatments are updated, so it's better to be safe than sorry and make sure we're looking that up. Okay, history. So for our history questions, kind of same as in the past. When we're talking specifically about the eye, ask about their visual assessment, when the last time they've gotten checked, because if it's been a while, it might be time for them to go back and get rechecked, and maybe they have different diagnosis. What is their visual acuity? Do they have stigmatism, which that third bullet point is stigmas, where there is an involuntary kind of bouncing of the eye, whether it's horizontal or vertical. Sometimes some people are born with that, and if they are, usually they would be able to kind of identify and tell us that. But if not, it could be an indication of some type of brain trauma, so we want to definitely go on and check that out. Have they ever had any type of previous injuries in the area or pre-existing conditions? For their general health, do they have any type of chronic illnesses? Are they on any type of medications that might alter, some of the insights that you're asking? And then also for the present condition, what are their current symptoms? Do they have photophobia, meaning are they sensitive to light? Is light kind of bothering them? Does it feel like they have something in their eye? Oftentimes, if it feels like they have something in their eye, they do have something in their eye, whether it's grass, a eyelash, turf, whatever the case may be. And that's what we're talking about with those foreign bodies. Is the lens displaced? Is there a corneal abrasion? Where I've had athletes, I was a track athlete who got a bug in their eye and ended up scratching their cornea. So that was another time where they needed to wear an eye patch and they didn't want to. Are they complaining that they have itchiness of their eye? So that's another good thing to kind of figure out what's going on. Okay, blunt eye trauma and the resulting eye pathology. So any of these mechanisms of injury can result in subconjunctival hemorrhage or retinal pathology. So it's still important that they get verified and checked. So this, and I don't know why this didn't come out as well as I thought. Sorry, the table is kind of oversized, but when we're looking, what we're looking at on here is the size relative to the orbit. So is it bigger or smaller than the orbit? Meaning, is it smaller like a golf ball or is it larger like a softball? The elastic property, is it hard, you know, like a baseball, softball, or is it elastic, kind of more like a tennis ball? And then the resulting pathology. So a large hard object, we're worried about orbital fracture or periorbital contusion. A larger elastic, we're worried about a blowout fractured, a ruptured globe, a corneal abrasion, traumatic iritis, periorbital contusion. And then the things that are smaller that could cause damage, a smaller hard also could be a ruptured globe, corneal abrasion, or laceration. And a smaller and elastic is going to be either a ruptured globe, blowout fracture, corneal abrasion. So any of those we're worried about. And it doesn't have to be an outside ball, you know, so to say. I've had athletes who have gotten elbowed and ended up with an orbital fracture, or if their head has hit the ground. So some other things to look at. When inspecting, we're looking at trauma to the external structures that might mask underlying pathology. So yes, you might have a bruise or a contusion, but what's going on underneath that? Are all the structures underneath still intact? Is there swelling or things that are going on that we can't see? And table 18-4 is what we'd just gone over. Obviously, anytime that we're in doubt, make sure we're referring them. The periorbital area, we're looking for discoloration or a hematoma. And then the gross deformity, obviously we can tell if it's a bony deformity, if there's any type of lacerations or specific swelling on the outside part right around the eye. On this, so when we're inspecting the globe, look at the general outside appearance. So this particular person, hopefully we can tell there are several lacerations. So one down here on the inferior aspect, one up here just above the eyelid, and maybe even something going on up here in the forehead. Okay, when we're inspecting the actual globe part, we're looking at general appearance. If there's been any type of, what do I want to say? If the globe has been ruptured, whether, there's an orbital fracture, we're trying to look at that general appearance of the globe, meaning, I can't say these correctly, guys, so I don't want to even botch that up for you guys. The inspection of the eye that reveals the globe to be bulging anteriorly is going to be exophthalmos. So that second one. If it's inferiorly, it's going to be that second one. Okay. Eyelids, is there swelling, ecchymosis, lacerations, sty? Usually when I see styes, I see it right on the kind of eyelid right there, either eyelid. And I'm told it's really, really painful. There's not a whole lot you can do for it, is just kind of warm compress and let it eventually go away. And then the cornea, if there's cloudiness, we're worried about intraocular pressure. So something's going on to cause additional pressure, so some swelling that are going on, and can cause a lot of pain. And then hyphema. And then hyphema is a condition that occurs when blood enters the front chamber of the eye between the iris and the cornea. So it's that anterior chamber. People usually first notice a loss of vision or a decrease in vision. It may appear to have a reddish tinge or a small pool of blood at the bottom of the iris or in the cornea. A traumatic hyphemia is caused by a hit to the eye from a projected object or a blow to the eye, and it can also occur spontaneously, so that also sucks. Make sure that we're asking them all of these questions as far as does it look cloudy when you're looking, and make sure they close one eye and then the other eye and make sure it's only that particular injured or affected eye. Okay, the next one, inspection of the globe, conjunctiva. So the kind of white part of the eye, is there a foreign body in it? Or is there a teardrop pupil? The sclera, so a black object by the inner tissue is bulging out. The iris can be inflamed, it's called iritis. And then the pupil shape and size. Anscoria. So anscoria is a condition characterized by an unequal size of the eyes or the pupils. So it actually affects up to 20% of the population, and usually it's harmless, but can be a sign of more serious medical problems. So if you're born with that, and usually physicians or ophthalmologists will have documented that. If it's not documented and we happen to notice it, we want to check and make sure there's no brain damage or any type of brain trauma that can and does occur. Okay, palpation. So when we're palpating, we want to palpate the bony structures. So we're palpating the orbital margin, so frontal and nasal bones. That orbital margin, so basically like around your eyebrow, and then all the way around. Okay, the zygomatic bones, and then now we're going to soft tissue. So, when they blink, whether they squint or open their eyes a whole lot, see if any musculature around there causes them any pain. And then the eyelid and surrounding eye. If we're worried about any type of fracture, we're going to end up sending them immediately. That way they can get x-rays and checked out on some further other things. Okay, vision assessment. We've talked about a Snellen eye chart. Sometimes there'll be a near vision card that you might be able to carry with you. Newspaper, that's kind of funny, right? Nobody really carries newspaper, but you can always pull out your phone, and they have got different apps that they can kind of help you determine what's going on as far as their visual acuity assessment. And then fingers. I tell you guys that I want them to follow my fingers with their eyes and not their head. Okay, we want to do this monocularly, so with one eye closed and only looking at and treating one eye, and then also with both eyes. If they wear corrective lenses, glasses, or contacts, make sure they're wearing them at the time of the assessment. And then when we're looking for pearl, pupils equal and reactive to light, we want to make sure that they are reacting equal and bilateral. So we're going to check one eye and then also check the other. If it's not doing that, or if one eye is more slowed or delayed in reaction, we're worried about some type of head trauma. And then the eye motility, just like I talked before, when we're having them look up, down, right, and left, we want to look and make sure it's smooth and symmetrical, and there's no kind of bouncing or jumping within the eye. And this is what I was talking about in all directions. So this one, besides kind of the plus symbol, we would also add a multiplication symbol or an X and a T, and make sure we're going through each of those different areas. Down here, we've got the Snellen eye chart. So, and what's important to note is over here on the right, excuse me, over here on the right, line 8 is 20 out of 20. So usually I would have them stand however, many feet apart, cover one eye, and then read the line lowest that they can visually see. So they might say, oh, I can see 7, and they'll go through it. Okay. Try and go one line lower and see if they can get all of those. If they can't, then they have 20 over 25 vision. And then I would have them cover their other eye, or, switch eyes, blink a couple times just to get their visual acuity, and repeat the steps. But instead of the same order, I might have them repeat in reverse order. So for line 8, one eye, I might want them to say D, E, F, P, O, T, E, C. And then when they cover their other eye, I want them to read the opposite direction. So it would be C, E, T, O, P, F, E, D. The reason, and unfortunately I have to do that, is because sometimes some of the patients will try and memorize that Snellen eye chart, where we're not trying to give them, good grade or a bad grade, but we want to let them know what their visual acuity is, and maybe they do need corrective lenses. Maybe that's why they're not able to see certain things, and it could make them a better athlete and better with their activities of daily living. Okay. Neurological testing, I've already talked about cranial nerves 3, 4, and 6, and that's with the eye movement. The optic nerve is cranial nerve 1. So each of those we're taking into account for concussion or neurological testing. Okay. Couple of different things that we're going to go into now is different eye pathologies. Okay, so we're going to go over specifically orbital fractures, corneal abrasions and lacerations, inflammation of the iris, hyphemia, retinal detachment, ruptured globe, conjunctivitis, and foreign bodies. Okay, the first one specifically is orbital fracture. So, with orbital fractures, we're worried about any time that there is something that's hard that hits us in the orbit. We're worried about blowout fractures and blow up fractures. Okay. Blowout fractures are the medial wall and floor fracture, which this is a picture of. Do you see the red arrow going down? And then the blow up fractures are the orbital roof fracture. Okay. Management, we're going to give them ice. And if they have pain with movement, whether they're looking in all different directions or they're having a hard time just looking straight ahead, we're going to refer them out. Okay, so if I asked you, what is a fracture of the medial wall or floor of the orbit called? You're going to tell me it's called a blowout fracture. It typically results from a blow to the periorbital from an object that is larger than the orbit itself. Orbital fractures present with the globe sunken and medially displaced or retracted in relation to the location and severity of the fracture. So when they're looking straight at you, it may look like, they have a lazy eye. And this table is what's in your book, talking specifically about the orbital fractures. Okay, hyphemia. So this is a great picture of hyphemia. I wish it was color, but this is what we had in our book. Usually the mechanism of injury is a spontaneous blunt trauma, and blood in the anterior chamber of the eye starts to pool. So with this, we're going to give them a patch and want them to shield their eye and then send them to the emergency room. In all honesty, if it was between 9 and 5 and we could get them to an ophthalmologist, I would prefer them to go there as opposed to an ER. But outside of hours, definitely send them to an ER, and it's going to resolve itself within 5 to 6 days, which is kind of nice. Okay, if you have a patient with hyphemia, you should place them in a semi-reclined position when they're being transported to advanced medical care. Why that is because it'll encourage blood to pool in the inferior anterior chamber of the eye. Okay, retinal detachment. Mechanism of injury, jarring force to the head. Some people have actually just done it by sneezing or in a laughing fit. The spontaneous ones are usually affiliated with Marfan syndrome. So more so higher at risk would be more the basketball athletes. I have had an athlete who detached her retina and ruptured her eardrum. She was a diver and she landed wrong on basically not parallel, but directly across her ear, and ruptured her eardrum and also detached her retina in that same landing, or I guess kind of belly flop. A lot of times they will say that it feels like a curtain came down. They might see flashes of light or have halos or specific blind spots. A lot of times this retinal detachment is going to require surgery. So it's definitely something that needs to get further medical treatment. Okay, and these are some of the tables for the retina detachment. Usually it'll require a CT scan. Okay, and for some reason, I don't have my this is on conjunctivitis. So conjunctivitis is inflammation of the conjunctiva, also known as pink eye. It's highly contagious. We want to make sure that you're not sharing towels. And if somebody does have conjunctivitis, they can't play or participate until they've been on antibiotics for at least 24 hours. And that's just because it is so widely spread. Okay, foreign bodies in the eye. So if there are foreign bodies like eyelash, grass, turf, rubber pellet pieces of turf, first we're going to try and flush out with saline. If that's not helping, you can get a wet cotton applicator to kind of blot out the body of it. But we want to make sure that we're not encouraging them to rub their eye. If they have something in, foreign body in there and it's trapped, underneath the eyelid, and now all of a sudden they're rubbing it, they run the risk of potentially scratching any different part of the globe. So we want to prevent them from doing that. Contact lens removal. So remove as soon as possible after the injury, because there's the highly probability or chance that different things are going to swell and it might make it more difficult to remove. First and foremost, try and ask the athlete if they can do it. They're very proficient and used to doing that. My worry is, I don't have contact lenses and I don't use them all that often, or ever actually. So I don't know how much pressure or little pressure, and I don't deal with that all the time. If they do have a hard contact lens removal, there's different applicators that you can use to take that off, but we want to make sure that we're opening the eye as wide as possible, pull laterally on the outer margin of the patient's eyelids, and while you're holding your hand under the eye to kind of catch the lens as the patient blinks or forces the lens out of the eye. Okay, penetrating eye injuries. Never, never, never attempt to remove the object. Okay, what we want to do is cover and protect the eye. So if you have one of those Gatorade cups, I highly encourage you to don't use whatever's in the patient's eye to make a hole in the cup. I would use, a key or something else so you're not putting any added pressure. But what we're doing is we're going to cover the eye, and you want to make sure you cover both eyes. So even if you tell them to close the other eye, they're not necessarily going to listen to you. So it's just better to start off with and make sure we're closing both eyes. Because if you only have the injured eye covered, the other eye moves and it will cause the injured eye to be moving at the same time. So we want to make sure that both eyes are covered to minimize any type of additional movement or additional pain, and then get them to the ER. So you're going to leave the object in place, stabilize it, and cover both eyes for transportation. Okay, chemical burns. So we want to irrigate with saline or water, patch the eye, and transport them to the ER with a sample of the chemical. Unfortunately, I've had to do this after a 4th of July. Neighbor kid was being dumb and had a fire extinguisher and sprayed my husband in both of his eyes, so he had chemical burns on both eyes. Definitely can't go to work or do anything with that. We irrigated with saline and water, and he ended up having to go to the ER. Thankfully, didn't cause any permanent damage. He did have to be home for about 48 hours and go daily to the ophthalmologist to make sure that he was making progress, but didn't have any everlasting effects in that. So that was kind of nice, actually really nice. Okay, and that was the last slide, but I know I've gotten a question before as far as what was the most catastrophic injury to a patient's eye, and that's going to be a ruptured globe. A severe blunt trauma delivered to the globe itself can result in a rupture of the cornea or sclera, subsequently causing it to spill its contents. It's a medical emergency that typically requires immediate surgery. So that's definitely, knock on wood, I've never dealt with that, but that's something that we want to make sure that we're treating, as soon as possible. I'm trying to go through here and look at my notes. Detached retina is what's going to be indicated when a patient reports loss of portions of the visual field, typically described as resembling a shade or a curtain being pulled over their eye. A patient suffering from when he or she is unable to focus on near objects is presbyopia. Remember, that's diplopia is double vision, myopia, and emmetropia. All words that you guys need to know. A teardrop pupil is of serious concern as an indicator as a possibility of a cornea laceration. Hyphemia is the collection of the blood within the anterior chamber of the eye. Exophthalmos is the eye globe being bulged anteriorly. The clear elastic structure located behind the iris that serves to sharpen and focus visual rays of the globe's posterior surface is the lens. And the conjunctiva is the thin mucous membrane that covers the eye that lines the inside of the eyelids. Feel free again to reach out to me with any questions, comments, or concerns, and I will be trying to get the face pathologies video up to you shortly.